Thank you again for the introduction. These are my disclosures. So in the field of machine learning, which we've heard about throughout the day, there's a certain type of machine learning called transfer learning that refers to the transfer of knowledge gained in solving one problem and applying it to solve a different but related problem. So in MRA, and in particular non-enhanced MRA, some vascular beds are simply easier to image than others, or it can be more readily imaged with better image quality, higher signal-to-noise ratio, spatial resolution, etc. For example, the intracranial MRA is much easier to perform than coronary MRA, as one example. So we hypothesized that transfer learning using a deep convolutional neural network trained on MR angiographic data obtained in one vascular bed could be applied to improve the quality or contrast of another vascular bed. And so we tested this hypothesis by applying a deep convolutional neural network trained on non-enhanced data obtained in the neck to non-enhanced MRA data obtained in the lower extremities. So these are our two data sources. We had KISS data acquired in the neck using a 3-shot radial facile angle shot readout with a golden angle acquisition scheme, which allowed us to generate a single shot image from just reconstructing the first shot, as well as a 3-shot counterpart, which was generated from reconstructing all the acquired shots. And our second data set was lower extremity KISS MRA data, which was obtained in 23 subjects, 20 of which were patients with peripheral arterial disease. And this was done with a single-shot Cartesian balanced SFP readout, so it differed in acquisition trajectory and also readout, and with a different background suppression scheme. So what exactly did we have the machine learn? Essentially, we trained it to map single-shot neck MRA data to 3-shot neck MRA data. As you can see here, where we have substantial undersampling artifact, it basically tries to learn how to map to this domain, and that's what the network was trained to do. How do we do this? We used kind of a conventional deep CNN architecture of a UNet with roughly 134,000 parameters, took small input patches and generated small output patches, and we trained it with nearly 1 million patches using 100-fold data augmentation using various kind of transforms as well as signal and noise incorporation steps. So what did we do? We applied this trained CNN to lower extremity KISS data, and the image reconstruction was done by tiling these overlapping kind of small patches in a weighted averaging scheme. And then we quantitatively analyzed the resulting images and compared them to the standard images in 3 locations, mainly the aorta. In one subject, we took a measurement in the iliac artery. The second location was the femoral artery, and the third location was in the anterior tibial artery in the calf. These were the quantitative signal analyses that we performed. We looked at arterial background contrast. We also looked at apparent contrast to noise ratio calculated using these equations. So looking at the raw KISS balanced SFB source data, you can see this is what the imaging slices look like. This is the source data. However, when we looked at what the convolutional neural net reconstructed, we could see basically look the same, but there's some important differences in overall image quality. First of which, if we just look at 3 different slices, we see there's a substantial reduction in apparent noise or signal variability in the background regions. And importantly, we retain both the large structures, arterial structures, and as well as small arterial structures. And that's really important. We don't want this network to be removing important anatomy in any way. So this is some examples kind of toggling between the standard and the convolutional neural net reconstruction. We see there's some contrast improvement generally, and these are full thickness maximum intensity projections. Here's some more examples. It's particularly kind of noticeable in this patient. These are full thickness MIPS, where using this CNN reconstruction, we kind of improve our overall contrast by suppressing kind of non-arterial structures. And importantly, we're not losing vascular detail, at least looking at these MIPS so far. Some more examples. Again, we imaged 23, we took 23 volumes and processed them in this manner. Again, just improvement in contrast with the CNN reconstruction. So when we looked at the quantitative measurements, when we looked at arterial background contrast on the maximum intensity projection images, we saw between 16% increases in the calf to 31% increases in the femoral artery on the MIP images. When we looked at source images, we saw between 14 to 21% increases in contrast. And when we looked at apparent arterial background contrast to noise, we saw substantial improvements, roughly around 115% in the anterior tibial artery and over 200% increase in the aorta here. These are all statistically significant differences. So in just kind of discussing these results, so despite the use of non-contrast enhanced MRA data acquired with different imaging protocols and in different vascular beds, deep transfer learning-based reconstruction improved the angiographic contrast and apparent contrast to noise when we applied this network and we transferred it to another anatomical location. And this is initial work, and we feel that with further validation and refinement, we foresee that this strategy of deep transfer learning will be useful for improving the image contrast or quality of MRA, especially in situations where routine acquisition of high quality or high signal to noise ratio images is technically difficult or impractical. Thank you very much for your attention.